Marnina Buddi, and welcome everyone to Grand Rounds for this week. I acknowledge that we meet today on the lands of the Kaurna people, the traditional custodians of the Adelaide Plains. I pay my respects to their elders past, present and emerging. I extend that respect to any Aboriginal and Torres Strait Islanders present here today. It's lovely to be joined by some people, a very select audience in the room, but if those of you who have joined us on Zoom want to come, you'd be welcome to pop up to be here in person. We will be serving a takeaway lunch afterwards, and I believe in honour of World Patient Safety Day that Lauren is going to give you some chocolate for attending, so not to be missed really. Moving on to the real business of today, it is my great pleasure to introduce our visiting Nimmo Professor for 2022. Associate Professor Christine Jackman graduated from Adelaide University in 1995 before completing her emergency medicine training at multiple sites across Adelaide. She had a fellowship awarded in 2004 and developed her interest in medical education during her training and has continued that throughout her career. She now has extensive experience working across 3 medical university courses in Victoria. She commenced as the Dean of the Epworth Clinical School in August of 2020 and as the Year 3 Coordinator and Integration Lead for the University of Melbourne Medical School MD program in 2021. Prior to joining Epworth, she was appointed as the Curriculum Lead for the Eastern Health Clinical School and as Acting Deputy Course Director for the Deakin MD. She has worked extensively in South Australia and Victoria, but also in Northern and Western Queensland. Through her work as a senior simulation facilitator and a facilitator training at Alfred Health, she's been involved in medical and interprofessional training and teaching communication at many levels of experience. She is passionate about medical education and in supporting medical students, junior medical staff, and experienced clinicians. So that's great for all of us, I think. She wants us to become the best clinicians that we can be, and I think that's a wonderful motto. She's going to talk to us today about some challenging topics, and I'm just going to get her slides up if you'll bear with me. Might do it with 2 hands. Welcome, Christine.
Thanks very much, Jo, and thank you for inviting me as the Nimmo Professor, and also a big thank you to Professor Chinley Lou Holmes, who was also involved in bringing me across, and it's a real pleasure to be back here at the Royal Adelaide. My memory of the Royal Adelaide is the old building down the road, and I remember doing the night cover. You know, we had to go across on level 4 and then go all the way over to the other wing, and it was about an 800-metre round trip. Everyone remember those days? Yeah, a little bit challenging in those days. I'd also just like to say that I come from the land of the Wurundjeri people of the Kulin Nations, and if there are any of First Nations people here today, I'd like to especially welcome them as I visit today. So I'm going to talk about something interesting today, and it's I'm passionate about communication skills, and I'm very passionate about how we use our skills particularly to prevent difficult situations. And so, just to start with, here we go. It's one of my favourite sayings. You know, the single biggest problem in communication is the illusion that it's actually taken place. And I think you could probably all imagine a situation where you thought you'd got the message across, and then subsequent events told you that you didn't, and things turned out very differently to what you expected. So there's a lot of common assumptions about communication skills. You know, one of it is that it's a soft skill. It's a soft social skill. It's an optional add-on extra, and that there's no scientific backing behind our communication. Another one is that it's a personality trait, that you kind of have it or you don't. And we all know those people who are particularly good communicators, and then maybe some that aren't quite so good. So there is a degree of natural ability in communication, but it's a lot more than that. You can be a fantastically coordinated person. Doesn't mean you're going to be a really good tennis player unless you actually practice the skills associated with that. And the other is that experience on its own is an effective teacher of communication skills. We know with any skill that to get better at it, you need to do it, but you need to reflect on it and you need feedback to actually work out if you're doing that skill well. And that's how we treat every other skill. If you're teaching to put in an IV cannula, put in a central line, intubate a patient, you don't just keep doing it over and over again. You actually get someone to give you feedback to see if you're doing it right when you're starting out. So why are communication skills really important? And there's been a lot of research in this area. So there's a lot of information, a lot of research to suggest that it really improves understanding and recall. And obviously that's really important with our patients who we're trying to educate. It's actually really improves symptom relief. And part of that is actually about how we set up expectations. It improves adherence and concordance. So that's, you know, if we want our patients to actually do what we want them to do, communication is really, really important. And it actually improves physiological outcomes. I guess even more importantly, that good communication improves patient safety. It improves patient satisfaction. And I'm not quite sure who all my audience is today, but it also very much improves doctor satisfaction. And that's really, really important, particularly at a time where I imagine a lot of you are feeling a little bit burnt out with what's happened around COVID and a lot of the strains of the health system. And I guess for our bean counters and our senior administrators, it actually decreases costs and it decreases complaints. So I'm going to tell a story. We're going to meet Fred. So Fred, he's day 3 of his admission. He's angry, he's yelling. He's actually hit a nurse. Code Grey's been called and he's now being restrained so that he can receive life-saving care. So have a think about that situation. Is that the situation that you want your patient to be in? I'm hoping you don't. So not a great situation. So let's take it back. Okay, let's meet Fred, day 1. Okay, so Fred, he's 58. He's turned up to emergency and he's presented with acute abdominal pain. He's been very efficiently assessed by Dr. Emergency. And the assessment has suggested the diagnosis of a small bowel obstruction due to adhesions. He's had a previous appendectomy many years ago. That sounds fine. And, you know, Fred looks okay, doesn't he? A little bit more about Fred. He was divorced 5 years ago. He's estranged from his adult children. It's a very difficult relationship. And he runs his own business. He's a landscaper. So what happens in emergency? So Dr. Emergency explains the diagnosis to Fred of the small bowel obstruction and a plan for admission into Dr. Surgeon for pain relief and IV fluids. Sounds like a pretty standard sort of thing that's going on here, doesn't it? Okay. But Fred's looking a little worried now, isn't he? Okay, so something's changed here. Just want to introduce the thought around assumptions. And I want you guys to think, what do you think is making Fred worried? Just take a minute to think about that. Why do you think he might have gone from, oh, I'm okay, you know, I'm a bit, you know, I was a bit worried because I've come in with abdominal pain, but now I'm very worried after this doctor has told me that I've got a bowel obstruction. I think, what do you think might be going on? Okay. Now, one of the problems is if we make any assumptions about what someone thinks and about what someone's experiencing, it can lead to a little bit of disaster. This is actually Katy Perry, and you might actually assume that the crowd would catch her. Didn't turn out so well. All right. So these are some of the assumptions you might have made when you were thinking, you know, he's worried because he's got a bowel obstruction. It might not have been what he was expecting. You know, it might have been, this might be a lot more serious than what he thought. He might be worried because he has to stay in hospital and that, you know, he's got his own business, he's a landscaper. But could there be more? Could he actually be more worried about something else that we don't know about? So the first sort of communication skill I just wanted to talk about is the ICE framework, and you've probably all heard about this. You've probably all heard about the ICE framework. It's how we it's a framework we use to explore patients' ideas, concerns, and expectations. And you know, when I've taught with communication skills, I have medical students who'll say, "Yep, I'll use the ICE framework, and you know, that's all fine." But there's thinking that and there's doing that, and that's very different. And actually exploring someone's ideas, concerns and expectations is really important, because how do you know you're on the same page? How do you know they've got the same idea about what's going on that you do? So let's explore this. So Fred's perspective, so his ideas, he thought he just had bad gastro. Okay, so yes, he had abdominal pain, but he was vomiting. He thought he had bad gastro. He was actually surprised even when Dr. Emergency said you need a CT scan. He thought he was just going to have a bit of fluid, be in hospital for a few hours and go home. That might not be unexpected, mightn't it? But Fred has actually got some very significant concerns. Fred's younger brother, Jim, actually passed away 6 months ago from metastatic bowel cancer. All right, and that's actually weighed very, very heavily on Fred. Fred, as I said before, he's estranged from his children, he's divorced. His brother was his closest social support. He died 6 months ago from metastatic bowel cancer. But Jim, his first presentation with bowel cancer was as a small bowel obstruction, which is actually a pretty unusual way to present. But Fred doesn't know that. Fred's got the n=1 scenario going here. This is his only experience with small bowel obstructions, is that his brother ended up having bowel cancer. He's been really worried, even before this presentation, about the possibility that he too might develop bowel cancer, because his brother was only 54 when he died. And he was meant to have a colonoscopy, but with the impact of COVID, his difficult financial situation, he's just not got around to it. So there's a little bit of, oh, I should have, maybe I've missed something here. Some of his concerns, some more concerns, he's got a lot of work booked over the next few weeks, but his business has been very quiet recently and he's under a lot of financial pressure, and he's actually facing the possibility of losing his business even before this illness. So there's a lot going on with Fred. And Fred is now expecting that Dr. Surgeon is actually going to break the bad news to him that he has bowel cancer, because his only experience with bowel obstruction is his brother, and that was bowel cancer. And we all know, as health practitioners, that that's probably the least likely scenario for this patient, but he doesn't think that. Okay. So let's meet Fred day 2. Okay, he's quite upset. He's in a lot of pain. Okay, his pain's not settling, and he's been thinking more and more about his brother and his, it's meant to be bowel cancer. Okay. So Dr. Surgeon comes to visit, and Dr. Surgeon introduces themselves and asks how Fred's feeling. Fred tells him he's in a lot of pain, and Dr. Surgeon immediately directs the nurse to go and get some more pain relief. Seems like a very appropriate thing to do. Yep. Dr. Surgeon explains that this is most likely a bowel obstruction due to adhesions, but if he doesn't settle over the next few days, that he may need to have surgery to resolve the issue. He's now introduced a new concept here. This isn't just conservative management. If things don't settle, he might need to go to surgery to solve the problem. It's very one-way communication. The surgeon's telling the patient. But Fred's actually getting now quite distressed. He's actually really quite worried about asking about bowel cancer because he doesn't want to look ignorant. He doesn't want to look like he's, misinterpreted this. He's a landscape gardener. He doesn't have any medical background. But he's actually now really anxious because his brother's cancer was actually found because he went to surgery. He needed to have surgery with his bowel cancer. So the surgeon says that there's nothing to worry about, everything will be okay. He's sort of seeing a little bit of that distress in Fred, but is saying, there's nothing to worry about, everything will be okay. So just a little bit more about the background with Fred's brother. So the initial cancer was actually misdiagnosed, and it was found at surgery when his obstruction didn't settle with conservative management. And his brother had actually asked about the possibility of cancer because there was a family history, and he was actually told everything will be fine. And now Fred has been told everything's going to be fine. So what's Fred thinking now? Fred understands that needing to have surgery indicates that it's very likely that he has cancer like his brother. He's now extremely anxious and he's starting to feel angry and frustrated, and he's starting to feel that people are hiding things from him. So what has Dr. Surgeon done here? And this is something that we can't help ourselves sometimes doing, and this is what we call blocking behaviour. So this is offering advice and reassurance before you've actually addressed the patient's main concern. And it's attending to all those physical aspects, like his pain, but without addressing the emotional aspect of what's happening here. So the Dr. Surgeon can see that Fred's really distressed. He may be making some false assumptions. He may be making the assumption that this is because of the pain and, you know, all those other assumptions that we made before. He may be seeing the distress, but be afraid to actually address this distress. So why are we afraid to actually acknowledge that distress and to name that distress? So one of the reasons is that we fear that we're going to unleash this whole flood of emotions, that we're going to unleash these emotions that we don't necessarily have the skills to deal with. Another big concern is that it's going to take too much time. If this person's really distressed and upset, if we need to spend that time with them, it's going to take too much time. And there is just deep down, and maybe even subconsciously, that if we always address people's emotional concerns, that some of that are going to transfer onto us. And that's actually going to affect our own emotional survival, because we're seeing a lot of pain and suffering, aren't we? That's what we do in healthcare. But the skill that I want to talk about now is, you know, how do we pick up and we reflect both verbal and non-verbal cues? We've got someone here that's really, really distressed. So how do we actually respond to that? What skills can we use to address that? So I want to talk to you about the nurse framework. It's not meant to be sort of discipline specific here. It's easy to remember nurse in healthcare. So this is all about how do we respond to emotions. And so naming the emotion is really important. Understanding it, understanding where it's coming from, respecting it, really, really important. Supporting, being supportive, and actually exploring what's happening. So let's just break this down a little bit. So naming it. So you seem really worried, Fred. You know, name what you're seeing. It's always good just to tone it down a little bit. You know, he might look extremely distressed, but you seem really, really worried, Fred. Understanding it. You know, I would really like to understand what is worrying you. Can you help me with that? Fred's already, you know, I've already said he's a bit worried that he's going to look like an idiot if he says anything to Dr. Surgeon. But saying, you know, I'd really like to understand what's worrying you, it gives Fred that out. He can actually say something now. And it also is very important that it's being said without judgment. So I'd really like to understand what's worrying you. You're not putting any judgment on that emotion. Respecting. Really, really important. So I'm very grateful you've shared your experience you had with your brother, and I'm sorry things turned out that way. So you've got to respect why they might feel the way they do. And everyone comes with a different background. Everyone comes from somewhere different. They're coming with different emotional experiences. And it can be really challenging to actually know what that is without exploring it. So supporting, you know. So I appreciate your concern that you may have cancer based on your brother's experience. Now, I'll do my best to talk you through each step of the way. So be really supportive. And then exploring it, you know. So I can't guarantee that you do not have cancer, but we can talk through how your current situation might be different to your brother's. So actually, you know, exploring it, seeing what things were similar, what things were different, and helping Fred to understand where he might be compared to Jim. And we can't say with absolute certainty he doesn't have bowel cancer, do we? It's extremely unlikely with all the evidence that's been collected. We can't say it with certainty, but we can explore how his case was different. So day 3, okay, we've got the final straw. Fred's continued to have severe pain overnight, requiring high doses of narcotic analgesia with associated worsening of his vomiting. even though he's got a nasogastric in. The attending nurse calls Dr. Surgeon to explain the worsening situation. Dr. Surgeon says they'll come and see Fred in the next hour, but he really thinks this guy needs to go to theatre now to sort out this bowel obstruction. So he's asked the nurse to get him ready for theatre. Sounds very reasonable, doesn't it? So the attending nurse updates the patient that the surgeon will be here in an hour and that they will be talking to him about the option of surgery. And they also explain that they're going to get him ready for theatre. Okay, seems all very reasonable. Fred's now not doing so well though. He's got a lot of narcotic analgesics on board. He's had a terrible night. He's had no sleep. He's terrified. He's absolutely terrified about what's going to happen. He feels that no one's listened to him, even though he actually hasn't said anything. He feels he hasn't had the opportunity to be heard. He's absolutely certain now that he's got cancer and that everyone's covering it up. He's in pain. He feels terrible. And he lashes out. He hits the nurse. He's lost it. All right. So we've now got an angry man with a severe bowel obstruction that needs urgent surgery. We've got a code grey that's been called. Oops, sorry, wrong way. Apologies. He's ended up needing to be restrained in order to receive life-saving surgery. And all the opportunity to talk him through the process has been lost. So let's reflect on this situation. Did anyone make an error with his medical care? Was his diagnosis correct? Yes. Was his management correct? Yes. Okay. So why did this go so pear-shaped and why are communication skills important? So coming back to where I started, okay, understanding is really important. He didn't understand what was happening. Symptom relief. His anxiety and his worry and his distress will have contributed to his experience of pain. And his physiological outcome now could actually be a lot poorer because he may have required medication to sedate him in order to settle him down. He's going to go to theatre, sedated, difficult anaesthetic. Things could actually end up a lot worse for him. When he wakes up, he's still going to be very anxious, worried, and probably very, very pissed off. And I'd imagine there'll be a complaint letter written somewhere. So our administrators won't be happy at all. So is this a safe situation for this patient? A lot of risk to patient safety here, haven't we? Not only his physical well-being, but his emotional well-being is at significant risk in this scenario. Do you think any of the doctors involved in this care would be really satisfied with this outcome? I think they'd be feeling pretty awful. And I can say that I really don't think the patient's going to be satisfied with this situation. So what made things worse? So assumptions, okay? Assumptions really can let you down. So the key thing with this guy was actually understanding where he was coming from, what his concerns were, what his ideas were, what his expectations were, and to actually address those and to actually be on the same page so that you knew where he was coming from. Blocking behaviour. So, and just think about it, everyone in the room, just think about it. Have you done this? In retrospect, have you done this? You didn't want to open that floodgate of emotion, so you addressed the pain or you addressed the shortness of breath or whatever it was that was important from a symptom point of view. And you could see there was something else the patient wanted to ask or say, but you just didn't pick up that cue, and you offered some reassurance before any of that concern was addressed. We've all done it. I'm quite happy to say I've done it. We've all done it. So what communication skills could have really prevented this situation? So using the ICE framework, and I'm hoping now you get a better sense of what this really means, exploring these ideas, concerns and expectations. And often this is quite easy to do. You know, one of the scenarios we use in teaching communication skills is a patient who's come in and they've broken their hip. Okay, and the scenario is set up so that she's been through emergency. The doctor there has told her she's broken her hip, And she comes up to the ward and it's the orthopaedic intern doing the admission. And one of the big assumptions that the students make when we run this scenario is that she understands what a broken hip is. But this lady's expectation is, oh, it's just a little crack and, you know, I'll just need some plaster or something. Has got no idea that this could mean surgery, that this is actually a really significant injury, that this has significant mortality, morbidity associated with it. That conversation hasn't been had. So actually knowing where that patient's knowledge is starting from is really important to talk about things, because the students will often say, you know, you've broken your hip, you need an operation. And the patient will say, what do you mean I need an operation? I thought I was just going to be on crutches. And that really changes the way they think. Picking up and reflecting verbal and non-verbal cues. So don't be afraid to follow the cues. It seems, you might think it will take you longer, but it will actually save you time. And sometimes it's not even your time, it's the next person's time. So what about all those people that came for the code grey? None of them, and we don't know if this would have prevented the scenario, but it probably had a good chance of preventing the scenario using these skills. But none of those people would have been there at all if the situation had been managed differently. So it may be someone else's time. And I guess to give an example, one of my colleagues is a breast surgeon, and she works in a breast clinic like you do when you're a breast surgeon. And she said often what happens is that she does follow up with patients, and that some of her colleagues don't address any of the concerns when the patient comes. And when you've been diagnosed with breast cancer, there probably are a lot of concerns. And then if she does the follow-up visit, she said she's then spending all this time, you know, going through the expectations, concerns, because her colleagues haven't done it. And she said it just makes her look like she's really slow. So it saved time for the other person, but someone else has to pick up that time. And it actually takes longer because now they've had a few months or whatever it is to dwell on it, you know, think about it, stew on it, and come up with lots of other concerns. Use frameworks to help you deal with emotions. And it might seem a little bit clunky to start with when you use a framework, but it's the same when you learn any procedure. You know, think about the first time you put an IV cannula in. You go, okay, what do I need? I need the cannula, I need the bung, I need the kit. You know, it seemed really clunky until you did it over and over again, and it became quite fluid. Dealing with emotions can be quite challenging, but anger and fear in a disempowered patient is actually a lot scarier. So if we think about why a lot of our people get angry and upset, you know, you look at the literature, it's because they feel disempowered, they feel that they haven't been heard, or they're just really scared. And they don't know how to communicate that in any other way. And just opening the door to communicate that fear can actually be so important in managing that fear and managing those expectations. It's really hard for someone to stay angry with you if you say, I'd really like to understand what you're feeling. And I'd really like to be able to talk you through and work through this together. It's really hard to have someone say that to you until you keep being angry and distressed. So use this framework. You know, nurse is just one framework. You might come up with something else that works well for you, but it's easy to remember. We all work with nurses. It's very easy. So just like to, thank you all for listening today. And we've got a small audience here and we've got people online, but I just would like to explore people's experience and to actually maybe start a little bit of a discussion about whether any of this rings true for anyone. If anyone can think of a situation perhaps that was a bit more challenging, and thinking about maybe how you could use some of these skills to change that outcome. So we've got some people here.
All right, thank you very much. We might start with some of the questions that have come up on the chat, but and I'll read them out for you. But I wanted to start by acknowledging that yesterday you mentioned about time, and if we don't spend the time initially, because we're trying so desperately to save time, it's like, oh, I've got a talker, oh no, you know, you want to rush on to the next patient. Well, no, this guy's really distressed, I'm going to tell him how it is and then I'm going to move on. But you said if we don't spend the time, someone else is going to have to spend the time. And I felt like that was a great little catchphrase. Who ends up spending that extra time, Christine?
Well, it can be a lot of people. So, like I said, in my example with this breast surgeon, that some of their colleagues have saved time, but she's actually had to spend a lot more time than perhaps at even the initial consult. Our nursing colleagues often end up spending that time and taking that time to explain things, and perhaps not always with the same depth of understanding of what's going on medically, which is runs the risk then of miscommunication as well. Their families. And we might say, well, that's their family time, that doesn't impact on the health service. But it does, because those people have jobs and they have lives and they have families, so you're taking them away from someone else. So it's one of the most powerful communication tools you can use, and people find this a little bit contradictory, but it's actually silence. So if you say something to someone, particularly if you're delivering bad, relatively bad news, silence is actually your most powerful communication tool, because you're going to say something and you've said something that's going to promote an emotional response. And you've got to give that person you're talking to, you've got to give them time to let that sit, to let that land, and to let that have its impact. Because everything you say, once you've said that thing that may be distressing, that patient's not going to hear, because they're stuck on that first thing you said. And you've got to let it land. You've got to slow your pace right down to their pace, because their mind, with all that emotion on board, is actually going to be moving at a very different pace to yours, which is on the ward round, or it's in the clinic, or wherever it is, where you're on a certain pace. You're going, yep, I'm getting through this clinic. I'm going to see all my patients. I'm going to be on time. Everyone got that feeling. Yep. But you've got this patient that you've just said, okay, you've got a bowel obstruction. And you've got to let it sit with that patient. And if you give that time to sit, then that guy, even just by doing that little bit of silence, he might have just said, oh crap, no, my brother had a bowel obstruction and he had cancer. And how much time would you have saved?
Lots.
If you'd known that just then.
A whole code grey, or I thought maybe a code black.
It could have been a code black by the end of it, but you didn't have a weapon, so
Because Jane Andrews has made herself very large on the screen. I don't know if you know Jane, you probably don't, but you are about 6 foot tall, just your head. So in the AD lecture theatre, so just make sure you don't do any witnessing like you just did. Would you like to speak to the? Don't do that. Please don't. Right. Do you want to just speak to the comment you put in the chat? Because you made a comment about management with opiates and.
Yeah, look, I think, can you hear me?
Yeah.
So in gastroenterology, if you're using opiates, you're really doing the wrong thing in general, and that goes for most of general surgery as well. So I just would like to make a plea that we don't underappreciate the risks of opiates and also of steroids. So I think there were a lot of alarm features that came out, not least of which was the communication. And I think failing to take a family history in a 50-odd-year-old guy who presents with a bowel obstruction around bowel cancer, that's also a problem. And it's really the stitch in time. You sit down on the edge of the bed and have a good discussion at the beginning and give that person some eye contact and get the proper story. And I totally agree, you will make many fewer false steps. And we probably should have, I don't know if he was ours or not, I hope he wasn't. Because the general surgeons sit under me, but he should have had an operation before he lost his shit, because that was all just a train wreck, and it's a sad story.
Yes, he was a composite patient. He was a composite of many patients.
Thank you. And there's some great points there, both about opiates, which have got so many downsides, haven't they? And also about the family history. I'd like to now move to Deborah put a comment in the chat where she ended with, nearly every step you describe in his care has left him feeling invalidated, alone, invisible, and scared. I don't know if, it's not a question, it's a comment.
It's a comment, yeah, and that's all really about the, when we talk about patient-centered care, but what do we actually mean by that? And that, this isn't about us, this is about our patients, and making them feel part of the process. Not making them feel part of the process, making them part of the process is so important. And, particularly those clinicians, for example, who manage a lot of chronic illness, where if it's managed really well, they actually don't have any symptoms, they don't have any problems. And that's always a challenge, isn't it? Because if you don't feel anything and you don't you're trying to prevent long-term complications. I always think of hypertension as being a really good example, that it's something, it's a disease process that if you manage it really well, nothing happens. And that's what you want. You want nothing to happen. You want them to be well. But actually, how do you get someone to understand that you're trying to prevent something down the track, and what that thing is that you're trying to prevent is that you've really got to get the patient's perspective on this, because they're not going to be compliant, are they? You know, that sort of days of people going, I'm doing it because the doctor said so. You know, we're raising generations of people who are going to query, going to be inquiring, are going to want to know, want to understand, but they also need to be motivated to do things. And if you don't understand where they're coming from, then you don't know. But you could tap into something that's really important. So it could be that they've had a relative that had a heart attack or a stroke, and there's something that they can really relate to and understand. You're probably picking that up in the family history, but you're going to use it in your discussion, aren't you? And of what you're trying to achieve. You're trying to prevent that. Or you can't prevent, but absolutely try and absolutely decrease the risk.
Now, Stephen McDonald raised that we spend much of our time relating to patients now in PPE and all the time in our masks. Any infection control is appropriate, but suggestions on how to mitigate the depersonalising effects on a confused and anxious person. And I think that is a real struggle that we've been facing.
Oh, absolutely. And I think there's nothing more, I think, powerful than a clinician sitting down with your patient. So pulling up a chair and actually getting to the same level. So if you're looking at each other at the same level, I always put that my really, really tall colleagues, that's always a challenge. But you know, you're sitting down and you're actually, just by pulling up a chair, can you imagine if you're a bit worried, a bit stressed about something, and you know, someone says, have a seat, and they pull up a chair. Okay, you've already, just that simple non-verbal communication there has told you this person is stopping. They've got the time, even if you don't, they've got the time, and they're going to listen to what I have to say. It's a really simple thing, isn't it? It's a really simple thing. Thinking about, you know, when you're on your, say, for example, on your ward rounds, how do you actually allocate roles in your team? Do you have someone who actually just goes and sits with the patient and, as things are being discussed, translates that for the patient into what it means for them? You know, that really simple thing. When I do my simulation training, we do a lot of high-fidelity simulation, and you know, we all think about, you know, if someone's arrested, you know, you've got your DFib, you've got your team leader, you've got your scribe. But when you've got someone who's deteriorating, I always, in that scenario, allocate one member of staff just to keep talking to the patient. Keep talking to the patient. People have done all sorts of things, like put smiley faces on their masks to make it more human, have actually printed masks with their own face on it. I find that a little bit creepy, a little bit weird. But you know, how you use your eye contact's really important. But you can't use your facial expression anywhere near as much, can you, when you're wearing a mask? So your words are really important, and your body language is really important to actually get the same sense of connection, because it's much harder connecting. And I remember working, you know, with an N95, a shield, in a gown, you're just quietly, you know, dissolving into a puddle of sweat. And your patient's hearing impaired and they're wearing a mask, you can't hear them, they can't hear you. And geez, some of the even, you know, resorted to the putting skets to go in their ears and talking to me at times, because, you know, it was just a nightmare to have that communication. So that body language is really important, you know, to get that connection, and recognise that you actually look quite scary in PPE. People look quite scary. Some people, somehow they can wear a mask and still look like the same person. You know, I just envy that person, but I just seem to just disappear into the mask, as a lot of us do. But yeah, some people, they can really get a lot of expression.
I'm going to let Maria ask a question. This is busting.
It's lovely to see you.
Yeah, good to see you, Maria.
I really think this is really important, and that we should be teaching medical students at a very early stage in their career. My question to you is then, how much of that is involved, you know, in medical education of our teams, medical students? I can't speak to local families not here, but just interested in what insights into that.
It's
just before, so that the Zoom audience can hear, Maria Delamel was asking how much of this is being taught to medical students. We don't know about Adelaide, but at Epworth, what are you doing?
Yeah, so at Epworth, we're a little bit constrained financially, as is every probably medical school. I can tell you though that Deakin University runs a very well-developed communication skills program. So students start, I think they start in second year, and then they run through third year, and their program is very much a building block program. So their initial communication skills program is very much around information gathering, and that's really incorporates that, you know, ideas, concerns and expectations. And then at the other end of that, they do things around like a risk assessment in someone who's potentially suicidal. And the way that you run these scenarios, we have really highly skilled simulated patients, and they're all actors. And geez, some of them are so good that they actually have to come out of character at the end, because the students are really worried that they are depressed and suicidal by the end of it. And that's not a good way to leave a simulation. And it's great because they come out there they're really happy at the end. But they're very, very good at this. And the way that you do this, it's like any simulation training, that you give students an opportunity to try, you get them to reflect, you get them to think about what they've done, what worked, what didn't work. You brainstorm with your tutorial group that you're working with, and then you get them to go back in and try again. So it's that really, if we're talking educational theory, it's that experiential learning, but with a cycle of reflection and repractice. And that's the thing. And then you've got to set up goals for what you're doing all the time. So now you've got to take that skill away and go, what are you doing when you're having conversations on a daily basis? So one of the really, really simple communication skills is, you know, how often have you done this where you ask an open-ended question and you get a bit of an answer, and then you just go and you ask very directed questions? So one of the challenges I put to students, can you ask 3 open-ended questions in a row? It's really, really hard. It's really hard. And sometimes I have to practice it by like just going when they get a coffee, actually talking to the person behind the counter. Because some of these guys, they've been communicating in 150 characters or less. It's actually really challenging to, ask a really open-ended question, because if you're, on Twitter or if you're on Instagram or whatever, you don't ask open-ended questions, because that's like anyone can assume anything if you ask that question. So yeah, it's really challenging. So Deakin has a really good program. Melbourne University, which is we run the clinical school for Melbourne. We also have Deakin students and Monash students at Epworth, because we have 11 campuses, so including Geelong. So the Deakin students are at Geelong. Monash has not developed a communication skills program. There's a little bit of lip service to it, so they talk about the skills. And same with Melbourne. Like you could say, the students could list all the things I've said here as skills that are really important, but actually not know what they mean in practice. They could tell you theoretically what they mean, but they actually don't know what it means in practice.
I'd like to invite Deborah, who's online making some great points in the chat, to turn on her microphone and talk to some of those points. Deborah, are you willing to do that?
I am, but I'm currently at home with RSV, and I could break into a coughing fit at any minute.
Okay.
Look, I'm a clinical psychologist, and I have a private practice and have an access appointment at the RA for research purposes. Everything that our visiting Nimmo professor has said is absolutely fabulous. But one of the biggest points that I get to spend an hour with each of my patients, which is an absolute blessing, because our doctors don't get to do that very often. And in that hour, they, they often bring me their results, which I say, look, I can't read these. I'm trained head and heart, but not a doctor. But I encourage them to take lists and ask questions, and don't be afraid to talk, because very often our doctors just are so busy delivering results that they just don't get the opportunity, mostly through time, of being able to do just what our guest is talking about, and that's just sitting with, and sometimes in silence.
Thanks, Deborah. It strikes me when we talk about communication, I always think first about how I'm going to explain something. but when you were talking, it was more about, did I wait and listen to what the issues were rather than barreling ahead? And I think that's probably a really, really important way of switching it around. Those who know me know that talking is something that I can do plenty of, and listening perhaps I have to focus more on. So I guess we get trained to, or encouraged to be the talkers that we are very often. In fact, I think in medical school we're encouraged to be less introverted and more talky. Steve?
So in this case, this hospital, surgery would take this patient.
Yes, yeah.
This is a 58-year-old guy who's come out of obstruction and surgery. Probably never to live by anyone, and I think we miss the opportunity for the admission process does. So when you take a full history, you run through things like you've taken and issues of routine, and then you would have said, I've got bowel cancer, and then you would have said, oh, have that happen, gives you the opportunity. And he would have said, so his occupation history, then I'm a
Landscape gardener.
So, hey, you might be as a human myself, how do you think you can manage after being in hospital for a while? Then you've taken a history and you've done a full examination. That would have given you an hour with the patient to sense that he was angry or upset, and you have the opportunity to do all these things. But we seem to consider it a partnership that someone on and takes that time to run the history. This idea that you have some tricks on what you're going to do
Yep.
ask open-ended questions. No one's actually
Sat down with them.
has actually committed the patient. Nobody on the book knows that this guy's got landscape. And it was somehow going to do it by magic, admitting, and by admitting,
So I developed this patient. It's not a real patient. It was an example, but my thought process around this was what would happen in private, for example, where the ED guys do a lot of the workup and then the surgeon picks them up the next day, for example. So they might come in late at night and then the surgeon sees them the next morning. And if there's problems overnight, the surgeon gets called. And one of the things that can get missed in the private sector is that admission process. And, you know, and I just wanted to go back to that, sort of the questions that we ask, that we actually teach our medical students that you need to know this. So therefore you need to ask this. But we don't say that you then need to listen to the answer. It's a small step, isn't it? That you need to listen to the answer. And, you know, one of the challenges I have teaching medical students, for example, is they get taught how to do a respiratory history, or they get taught how to do a cardiac history, or whatever it is. But what we want them to do is actually get this patient's story and get a narrative of what's happening in this person's life. And that's actually a very, very skillful thing to do. It's actually a very skillful thing to do, because the biggest thing you need to do is actually listen. And you're using clarifying and directing questions. And you might say, okay, so, your family history, brothers have got bowel cancer. And then you might say, can you tell me a bit more about that? What happened with your brother? That would be the logical follow-up question. And that gives the human that opportunity. And then if he looks distressed talking about that, then you've got that opportunity to say that, obviously you're really distressed about that. And given what's happening now, that makes a lot of sense to me. So let's talk it through. And does it take a lot of time? I think it's more about how you use your time than the total amount of time that we're talking about. It's actually asking the right questions. But as I said, I can't emphasize enough, it's about listening to the response. It's about picking up the cues your patient's giving you. And when I run these simulation scenarios, you'll get a patient that's just, because the sim patients are fantastic, they'll be dropping these huge cues and the student just won't follow them. They just will not follow the cue. And when you explore why, they go, I didn't know what to do with it. I didn't know what to do with that cue. I just didn't know what to do with it. So I just soldiered on, allergies, medications, whatever it is. Yeah, so yeah, it's really challenging. And, you know, again, we're living in a world where, you know, particularly in Victoria, had huge amounts of isolation where people haven't been socially interacting with each other, just been getting to know their own family members really well. That can be a good thing or a bad thing. I think the dog got sick of us. They've lost some of that social skill as well. That, you know, and that's often my advice to people, you know, you go get a coffee, talk to the person behind the counter, actually have a conversation. A little conversation, it's not going to be deep and meaningful, but practice that conversation and practice listening to that answer. Because it make that person's day better anyway.
For sure. Lauren, go ahead.
I think Steve just brought up one of the issues that was on my mind as you were putting this patient forward, which is, as I guess, clinical leaders, is how we can make the environment suitable and appropriate to do a good job at these skills. So these are something that I hope most of us at the consultant level would have a reasonable sort of toolkit to draw from. But the environment and the systems that are in place at the moment are such a barrier to applying those things. You know, you might not have a junior in the room because they're on the phone and off sick and down the corridor doing a consult and around the corner doing a vet call and no one's sitting with the results. And you know, the electronic systems don't support us because to find the 30 bits of data you need takes 15 minutes and 20 million clicks to find the bits of data that you require to find the admission note that's buried at the bottom of the ED thing, or you know, you can't find the SAS note and the call is gone missing, or you know, there's no chair to sit down and you have to go on for days.
Yes. Yep.
It's possible that I could have seen that patient that the morning they are very distressed with a handover from someone else, and then you're dealing with an impossible situation with something you couldn't have changed beforehand. And then you're actually facing violence in the workplace, and the support for staff in that setting as well, I don't think is adequate. Or for that nurse, like I understand the patient is in a terrible situation. And I know there's probably nuance in the situation when you present that he was more delirious or incapacitated mentally than
Absolutely. Yep.
what I had initially read. But, you know, technically, if he's not incapacitated and just angry, there's the legal issues there about restraining him and, you know, and also protecting staff. And so I think there's just so many layers there which the system around us needs to support us better so that we can implement those skills. And I think that's the challenge we've got now in our hospital environment, is how can we create the systems and the environment to enable us to do a good job at this, because I just feel like the barriers are so high and never been higher for me to do a good job on that face water round. It's never been harder to do a good job than I have to now compared to any other time in my career. So I don't know what our people online or in the room we can do to help with that, but I think we need to be addressing those system issues, because we constantly tell ourselves and each other to just be better and do more. And you can only do that for so long before everyone just buckles under the demand.
You want to have a system that allows the doctors to do the doctoring, that you're not doing things that aren't doctoring. So, you know, we're highly trained as doctors. We have a very broad skill set. And, you know, I remember in emergency, I'm ringing another hospital and I'm faxing through a request to get results from somewhere else. And I was thinking, you know, when I left South Australia, you could actually just get them all. But, you know, now I'm in Victoria and you've got to, who faxes? You know, that's like 80s technology. But then you have to get a signed consent from the patient. I've got a patient who's dying here. Can I just get this information? I want to know, you know, what happened at, you know, Hospital X. You know, and trying to get out in one of the places I've worked, trying to get the admin staff to actually do, you know, like admin, it was just a nightmare. And you go, how do you function well in that environment? And that's, I guess, the challenge for our, you know, our leaders in the space. You know, how do we get doctors back to doctoring? I think probably one of the saddest things I've heard recently is one of my students say, you know, they're a final year student and they've done a lot of, we call them pre-internship placements, and in private we don't have interns, so their final year students effectively work as interns. And she said, oh yeah, I've just had a whole year of, you know, doing paperwork and being slave labour. And I'm like, well, you know, hopefully there was a bit more in that than that, but that's actually what she's going to do as an intern. I mean, she was doing admission notes, she was doing discharge summaries, she was writing progress notes, she was doing, chasing up results, she was actually assessing patients after the round, and exploring some of these issues, but couldn't see any of that. Could only see that she was doing the paper. And that's, is that what doctoring is? Even if we just had voice activated notes, be hard because there's a lot of ambient noise usually in a hospital, but voice activated notes, how much easier would that make things?
Jane Andrews feels like the chair would be a simple fix. I've been typing what you've been saying. Jane Lee, you've got your hand up. Do you want to show us your face and your voice and ask a question?
Well, I don't want to be 6 foot on the screen, so.
Oh no, you're in luck. Jane's still on the screen.
All right, excellent. Hi. Thanks, Chris. That was absolutely brilliant, and I think a talk that we really needed to have at this stage. I've been sitting here mulling over how to say what I wanted to say, and I couldn't have put it better than how Lauren just beautifully articulated it. I think that a lot of people have great communication skills and ordinarily would never think that they would forget to clerk a patient properly or take a family history, and do want to sit down with the patients and spend that time listening to their fears and really hearing them. But the system that we are in at the moment is a bit at odds with that. So we all want to do that as doctors, but the messaging we're getting every day is, we need to get people out, we need to do all of these tasks, we need to move from one task to another, and we're literally lurching from one thing on our to-do list to the next, and there isn't often time to sit down and spend that time. And so I think actually, to the group, bringing it back, that this is why we're all here, to be what the individual patient needs at their time of vulnerability, and that is the job that we're here to do, is a really important starting point for discussion about how the systems can support us to do that for patients. And I saw that someone else wrote, a stitch in time saves 9, and I think that's really important as well, because often you look back on a sequence of events that led to the patient being really displeased, and you think, okay, if someone had spent 30 minutes instead of 5 minutes 3 days ago with this person, then that would have de-escalated a lot of the situation. And to me, the chair not being there, I think, is almost symbolic, that there's no chair to sit in some places, and in other places there is a chair always to be found. I think we need to create a system where particularly the people on the ward, the people in ED, the people who are often on the fly, can provide this level of care. Thanks, everyone.
Thanks, Jimmy. Yeah, it is the challenge of modern healthcare, and I really love the analogy of Star Trek, where all your diagnostic stuff is just with a tricorder, and so what the doctor is actually doing is all of the communication, because you've got all these things that go beep that can tell you everything else. And people have looked at, can a doctor be replaced by Google? And I don't know if anyone's seen those little gifs that are going around, is please don't confuse my medical degree with your Google search. That there's actually a lot more about being a doctor than the knowledge that you have. It's actually the skills that you have, which actually differentiates you from just a symptom checker online, because everyone can ask about symptoms. I could give, Joe Blow, who's walking up North Terrace at the moment, a sheet, and they could ask those questions and go, yes, yes, no, 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 no. But what you bring as a doctor is this other skills that we may not always appreciate, and we may not always appreciate in training, is that it is that understanding, it is actually having a sense of how an illness might impact on someone much more broadly than just what you're seeing in front of you.
And that is a big domain in the long case of the physician's exam, which I've always thought was so important, and I love marking to that domain. Victoria.
Do you have any advice on sort of applying those communication techniques to like your colleagues and junior doctors?
Yeah,
because I think people have talked a lot about the barriers, about time and that kind of thing. But like I've watched colleagues who have stay till 8 p.m. at night, their grandma's just died. They come around on the ward round and criticise for not ordering iron studies or this target. And then they're just trying to
hold it together,
stay alive. And so they're not going to ask the patient, what are your ideas of consent? Because no one's asked them. Yeah. And it's even harder for the bosses to make time to ask them. And so how do you ask everyone in the chain
Yeah, so I guess that's all around teamwork and communication, isn't it? So that's another field that I'm really interested in, that you know, everyone in a team can have a bad day, and actually empowering your team to say, look, I'm not 100% today, got some stuff going on at home. Can I just take the role today where I'm just going to write in notes because I don't have that emotional energy to interact today? So as a team leader, if you're the consultant, for example, as the team leader, you actually empower your staff to choose their roles to a certain extent on a particular day, or you allocate roles, but empower them to say, actually, I can't do that today. I just haven't got the headspace to do that today. So it's really challenging. You know, you look at that, say you look at a sports team, for example, and there's going to be someone that pulled up sore at training, or, you know, isn't 100%, but they're not going to tell the physio because they want to still play because it's the AFL or whatever. But your team will work around that. You know, often teams will play someone who's not 100%. You know how they do their fitness test? They need a fitness test. They're not 100%, are they? Something's troubling them. So the team will actually work around that deficit for that match, and then that person gets better but then someone else in the team has something else going on. We can't work at 110% all the time. It's just not possible. And our health system is expecting us to do that at the moment. And it's just not possible. And the systems are, you know, incredibly important to allow us to do that. But actually how we communicate with our team is extremely important. But you can actually, you can actually go, okay, we've just saw Mr. Smith on the round. I'm actually really worried, he's a bit concerned. Why don't you just, you know, whichever staff member, you drop back and just have a chat with him about his concerns, so that we know that he's heard, and we know, you know, we can just touch bases after we've seen these next few patients or whatever it is. So it's actually using your whole team to the maximum of their resource is really important, but challenging, because you got to think on the fly all the time. Yeah, and keep adjusting your team.
We are over time. Feels like we could keep going, but thanks everyone for participating online and in the room, and thanks very much, Christine. Please join us next week for the Nimmo Prize presentations, and also there'll be a fantastic World Safety Day presentation which people should think about coming to. Thanks very much. Very lively in the chat.
Discussion.